The second presentation will be held by Dr. Alison Kerfman, who is a pediatric emergency medicine physician at Mercy Clinical in St. Louis. She also serves as a medical director for pediatric virtual care at Mercy Virtual and has launched virtual care programs for complex pediatric patients, neonatology, and pediatric emergency medicine. Dr. Kerfman co-founded Sprout, a multi-center research network dedicated to high-quality pediatric telehealth research, and currently serves as an executive committee, also for the AAP, American Academy of Pediatrics section of telehealth care, and speaks and consults with telehealth system on implementation of telehealth in pediatric initiatives, digital health transformation, and change managed in healthcare. Dr. Kerfman, we please ask you to share your presentation and tell us a little bit more about those projects.
Hi there. Thank you for having me. Can you guys hear me?
Yeah, thank you.
All right. Well, I really appreciate the invitation, and I'm excited to talk to you guys today. Let me see if I can share my screen. Okay. All right. All right. Are you guys seeing my screen now?
Yep, thank you.
All right, great. So thank you so much for having me today. I'm very honored to share with you some of our learnings about pediatric virtual care and telehealth at Mercy. All right. So to start, I want to talk about the concept of disruption. So for most people, the word disruption kind of brings on a feeling of concern because it's a challenge to the status quo. Disruption is, in my mind, the theme of the year 2020 so far. I'm a physician and I'm also a mom of 4 little ones. And this year has really taken some bizarre turns. We had to experience the healthcare system from the perspective of a patient this year. We started our year off with an unexpected neonatal ICU stay when my youngest daughter was born. Followed by an urgent, unexpected surgery for me, and then navigating well baby care with a high-risk newborn during a global pandemic. Earlier this spring, my family was featured in a local publication describing the impact of COVID on healthcare workers and their families. When my youngest daughter was only a few weeks old, I unexpectedly had to return to work to help with the COVID response. So this is just one of many examples of how we as humans have had to adapt to really rapid change this year. We've all had to alter almost every aspect of our personal and professional lives to adapt to the disruption caused by COVID, and it is pretty exhausting. So if disruption is a word that makes you feel some unease, you're not alone. But when you couple the word disruption with innovation, the meaning shifts. When it comes to technology and change management, disruption is really the path to transformative change. It's an adjective that stirs feelings of excitement, creativity, and hope for the future. Because the truth is, we can't get to where we're going without changing where we are today. 2020 has uncovered some really ugly truths about the healthcare system, but it has also kickstarted a really phenomenal pace of change management and innovation. And I believe that this is only the beginning. The next decade will include an evolution of healthcare that occurs at a pace that has never been seen before. Healthcare systems are traditionally structured and led with a fairly hierarchical and rigid, slow to adapt approach. So why is that the case? It's because we're caring for people's lives. Resistance to change in healthcare is truly based in the most core belief that we want to make sure we don't make mistakes and changes that could cost someone their life. But there is an opportunity cost to resisting change. The next few years promise to be a rapidly shifting environment with significant integration of technology. And as healthcare systems, we need to be prepared for this rapid and constant change. And preparing our leadership and frontline staff for new ways of approaching change is going to be necessary if we want to continue in our mission. So the opportunity cost of not being prepared for change is the risk of becoming obsolete. If your healthcare system ceases to exist, then you won't be able to continue the very worthy mission of helping the sick. So the good news is we actually don't have to reinvent the wheel. Many other industries have gone through the somewhat painful process of digital revolution. And we can absolutely learn the keys to success from our friends in the technology and software development industry, e-commerce, transportation, finance, and many others. I've personally learned a lot about industry disruption from a good friend of mine who founded a mattress company called Casper and upended the whole mattress sales industry. So I'm really excited to learn about this K.I.D.S initiative in Poland and the approach you're taking to innovation in healthcare, particularly the concept of learning from other industries. This is really not a linear journey. It's shaped more like a roller coaster. So I think we need to just be completely ready for a new experience. So today I'm going to share with you some of my ideas about the future of pediatric healthcare and why pediatrics has a unique place in today's healthcare transformation. I'm also going to share some resources for collaborative research in telehealth. And I will specifically address the use of telemedicine or virtual care in the care of children and give examples of some areas within pediatrics that have already shown life-saving, financially sustainable progress using relatively simple technology. I will also share in detail a case study of a groundbreaking program designed to care for the most medically complex and vulnerable children, including clinical and financial outcomes, challenges, and keys to success. I do want to make a disclaimer about virtual care in pediatrics. Virtual care is not a specialty, it's a tool. So as medical students, we are taught how to use a stethoscope as a tool. We learn which way the earpiece points, how to use it, and the benefits and limitations. And much like a stethoscope, clinicians must be trained how to use virtual care as a tool. But the tool itself has to become integrated into the standards of clinical quality and patient safety that have been established over decades of modern medicine. So one challenge in healthcare innovation is the need for a strong evidence base to determine best practices. And that was really lacking in this field. So in 2016, I co-founded Sprout, which is a research network that aims to foster collaborative research in pediatric telehealth. We have over 150 participating institutions, and we really welcome international sites to participate as well. So definitely reach out to me if your institution would be interested in collaborating on any research. So there's a few things that make pediatrics unique in this space. Pediatric specialty care is not available in all areas and is usually centralized in urban locations. This means that a large portion of the population does not have access to specialized pediatric care. I like to say that pediatric patients are not just little adults. We use different resuscitation algorithms, medications, and dosages, and kids have really unique pathology. I am a pediatric emergency physician, and my journey in pediatric telehealth started several years back with a case that I will never forget. There was a little boy who was only 2 years old who was in a rural emergency department, and he needed to be transferred to a children's hospital. The physician in the other emergency department knew that something was wrong, but he did not have specialized pediatric training, and he couldn't even fully describe the clinical exam. Without being able to see the child, the pediatric emergency physician was blind to the fact that he had an unrecognized head injury. So with severe head bleeds, there are medications that can be given prior to transfer to protect the brain. But unfortunately, in this case, the child did not receive those measures and he died during the flight. I really could not shake the feeling that this may have been preventable if only the pediatric doctor had been able to see the child before they took off. It seemed so simple, and the technology to video conference is so easy and integrated into our other day-to-day communication. And it made me wonder, why weren't we using video technology integrated into our healthcare? It turns out that even if the technology is simple, the change management is not. So there are a number of ways within pediatric care that using video to connect with patients can transform the current care model. In emergency medicine and critical care, the ability to remotely provide pediatric expertise can be life-saving. Two of the most critical locations for life-saving care are in the emergency department and in the delivery room. So there's actually many examples of children whose lives were saved due to intervention over video with a pediatric expert. In one case at the Medical University of South Carolina, a young girl with a severe head injury was evaluated over video, and she did receive those medications prior to transport to protect her brain. She was rushed to the operating room as soon as she reached the pediatric hospital, and she survived with no neurologic injury. In another case at Oregon Health and Science University, a baby was born in a rural hospital and had no respiratory effort or heartbeat. The team was performing CPR on the baby, and since the neonatologist was able to visualize the resuscitation on video, she could immediately see, sorry, can you guys mute yourselves? Thanks. She could immediately see that the team was not providing adequate ventilation. So without properly breathing for the baby, they had no chance of getting her back. With some very specific troubleshooting, the neonatologist was able to direct the team on technique, and the baby's life was saved. And at the University of California, Davis, a baby with a critical heart defect was seen in a rural hospital and nearly died, but the remote pediatric critical care doctor recognized the subtle signs of a disease process that is unique to neonates and instructed them to give her life-saving medications prior to transport, which she would not have survived without those. So all of these are examples of the profound impact that virtual care can have on pediatric health in critical situations. But in addition to interfacility telemedicine, where video consults are performed between hospitals, there are numerous options for ways to connect to patients in their home. So chronic disease management and specifically complex care, which will be the focus of today's case study, makes a significant impact on child health. Additionally, many acute pediatric issues and preventative maintenance can utilize technology to improve access to healthcare. So with that, I'll describe a little bit about the hospital system I work for at Mercy. We have a total of 45 hospitals, including 2 pediatric hospitals. And we have a unique innovation branch of Mercy called Mercy Virtual. We built the first ever fully virtual hospital, pictured here, as a hub for the development of all of our virtual care solutions. I'll make a quick disclaimer that although our building is really beautiful, there's really not a need for a brick and mortar solution to implementing virtual care. Any hospital system can invest in infrastructure, change management, and technology solutions without raising capital to build a freestanding virtual care hub. So when I started at Mercy Virtual, our objective was to lay the groundwork for pediatric population health. So most kids are healthy at baseline, and their needs include preventative and minor acute care. Some children have a single chronic disease, such as asthma or diabetes. And in addition to their preventative primary care, they have special needs for their chronic disease management. And a very small portion of children are considered medically complex, children with multiple severe chronic illnesses. In the US, children with medical complexity represent less than 1% of kids, but they account for almost half of all pediatric healthcare costs. So we focused our first pediatric virtual care program on complex care for kids because we knew that there was significant opportunity to improve the care model for these children. There's so many unique aspects to caring for kids with special needs that must be considered. And we use this framework to address each of the aspects of care for these patients and their families. Our initial funding was from Mercy's innovation budget, and our objectives were really straightforward. We aimed to create a virtual care model for complex kids and demonstrate improved clinical and financial outcomes in this population, and to keep them home and out of the hospital. Our team included a physician, nurse practitioner, nurses, and a social worker. So I'm going to show you a brief video to show you our program in action.
We have one patient in the program that lives 30 minutes from the closest road. With virtual care, we can augment the traditional healthcare setting and meet these patients where they are to try and catch things early. It's very scary to have a child at home who's sick. But imagine how much more terrifying it is when your child has multiple medical issues, is dependent on technology and a ventilator and equipment to keep them alive, and you live far, far from the closest hospital.
It's just kind of nice to have an extra arm to help kind of become part of our little family.
Many of our patients are located in rural areas. Tobias is a 4-year-old born prematurely at 31 weeks and had a lot of interaction with the healthcare system. At the touch of a button, we've been able to really help assess him when he's sick to get him to the most appropriate level of care. Nurses, nurse practitioners, physicians, and a social worker. So we try to really initiate more proactive care and preventative care. We've already avoided a significant number of emergency department visits. There have been many cases where parents are calling in and they're very fearful about their child's symptoms. And oftentimes we're able to assess them over video and actually provide comfort to parents to know that somebody else who knows their child and their trusted healthcare team can see their child and provide that level of support for these families that have never had that before.
All right. So let's see if I can.
We have.
All right. So we customize equipment for this program based on individual patient needs. And we learned the value of simplifying our equipment kits to meet our objectives. There's really no shortage of products that you could consider when starting an in-home monitoring program. But we learned what equipment was needed and what was extra or unnecessary. We also learned the importance of connecting patients on their own devices. Not only did it lead to significant cost reduction, but our patients were more engaged with the clinical staff when they used their own personal device than when they used a hospital-provided device. The key components of our model included a proactive appointment at the beginning when the child was well. And this appointment included meeting the team, extensive medical record review, and contingency planning. We also communicated with all specialists and ensured that their action plans were up to date and that the family had everything they needed at home to implement that plan. Once a child was enrolled, we had regularly scheduled touch points, including a daily digital survey, preventative phone and video visits, and the availability for acute escalation of care when problems would arise. Our protocols were well defined ahead of time and ensured that we could connect with patients using the most appropriate staff member, so a nurse, nurse practitioner, or a physician, and the most appropriate means. Hang on, I think I lost my screen. 1 second. All right. And the most appropriate connection, so text, audio, or video. We also provided resources to address significant social needs as well as mental wellness resources for patients and parents. And here are some of our results. So after the first year, we had enrolled 83 patients in the program, and compared to the 12 months prior to enrollment, their hospitalizations decreased by 26%, and their emergency visits decreased by 42%. The monthly charges decreased by $7,400 per patient per month. These patients have extremely high cost of care, and by keeping them healthy and out of the hospital, we saw a significant reduction in their costs. In the second year, we grew to serve 141 high needs kids. We had 229 instances documented where the emergency department, which is the most expensive place to receive care, was avoided. On average, we had 15 touch points via text, phone, or video with each patient monthly. And compared to the current standard of seeing patients annually or quarterly, this program demonstrated that a key to success is having really regular contact with patients. In at least one case, the team provided life-saving care. In one case, there was a baby who was only a few months old and had recently been discharged from the neonatal ICU. One Monday morning, we received a message from the caregiver that the baby, who had lung disease, had a brief drop in her oxygen level overnight, but that the issue had resolved. The pediatric nurse got on video right away with the caregiver, and she could immediately see that something was wrong. The baby did not have a normal respiratory effort, and while her oxygen level was normal, she was not ventilating appropriately. And this is something that could not have been noticed over the phone. The video component gave us the unique ability to have pediatric trained clinicians look at the baby and see that something was wrong. So the team immediately began giving instructions on how to start breathing for the baby and called emergency services. When the paramedics arrived, they also were overwhelmed with the severity of the baby's respiratory status. And I was able to give them very clear step-by-step instructions on pediatric critical care. The baby was transported to the emergency department, where she was found to be in respiratory failure. The critical care team worked on her for over an hour and then finally called us to let us know she was stabilized. They said that if she had stayed at home any longer, she would not have survived. So that's one of the more dramatic stories of the impact of the V-Kids program, but there were many, many times that V-Kids made a significant impact on the life of a child. We also have a complete economic evaluation of the program that's currently in progress. So we're working on two separate publications. One is an economic framework for the measurement of telehealth programs, and one is a full evaluation of the economic impact of the first 2 years of the program. Economic evaluation has to include more than just dollars saved. We can also measure quality of life measures, such as days spent at home. So this slide demonstrates some of the most common interventions in this patient population. And one of the key takeaways of the program was that it really required transformative change rather than incremental change. So it wasn't enough to just slightly alter the way we're delivering care or to just add a video component to the current standard of care. We instead built a system for these kids based on a vision of what was truly needed, a whole health program with a supportive team. One of the most impactful areas of the program was care coordination and a centralized team. The virtual team provided support to both families and physicians to make sure that the kids were getting what they needed. It was important to not get carried away with the technology we were trying to implement in the home and instead start with the MVP, the minimum viable product. And finally, the importance of the pediatric medical home is significant. The care provided through this program was in collaboration and support of the current physicians. It's imperative that virtual care be integrated into our systems and not operate in a silo. So as you can see, we discovered tremendous value in pediatric virtual care. And there are several things that make pediatric populations unique. So first and foremost, it's almost universal that we as humans care about kids. Kids represent the future, and it is pretty much biologically hardwired into us to want to help kids. There's a lot of unique funding and fundraising opportunities in pediatrics, as demonstrated with this Kids Foundation. There are a lot of people who want to help improve healthcare for kids. Additionally, this younger patient population and their parents are more tech savvy, and they're more comfortable using their own smart devices and trying new ways of accessing healthcare. Also, the population health implications are significant, particularly since we're intervening so early in life. The ability to alter the trajectory of a disease state in childhood can have a lifelong impact. And finally, in a value-based system of care, this model is not only impactful, but also financially sustainable. The exact model for complex kids can be applied to single disease states as well as preventative and acute care. So I mentioned at the beginning of the talk that the funding for our program was provided by our innovation budget. The United States is unfortunately in a fee-for-service system of care, not value-based. And implementing this complex care program saved significant dollars for the health insurance companies, but at a cost to our organization. So a few months ago, when COVID hit, the US healthcare system suffered devastating financial losses. The program was unfortunately impacted, and we lost some funding resources. Our work is still being continued, but it looks different today than it did in the spring. But our hope is that the lessons learned and outcomes demonstrated over the past 2 years can be a guide for other children's hospitals to implement similar impactful programs for kids worldwide. So with that, I want to challenge you. When you think about your own organization and look at the road ahead, I want you to ask yourself, who are your thought leaders? How prepared are you for change management? Are you training your leaders and your staff how to be agile and the critical skills needed to adapt to rapid change? The journey is kind of like a roller coaster, and it's really just beginning. So with that, there's one more picture of my cute kids. So thank you.
Thank you. It's impressive. It's really hard to compare this to what we have right now in Poland. But to tell you the truth, when I was listening to this, I was really amazed on how good you take care of those children there, and especially that you take care of those high needs children, because the first thing that comes to people's mind when they think about telemedicine is that this is a possibility to consult, minor conditions like sneezing, like cough and stuff like that. But you really take care of those really high need children, and the situations and stories that you've described when people were teleconsulting, ICU cases. That's even more impressive. And lots of time when you speak with doctors in Poland, especially, and I guess in the world as well, and that comes from the style we are trained in, that you always have to touch this patient. You always need to see this patient yourself. There are many restraints and constraints when it comes to telemedicine in people's head. But you really prove here that this is only things and only fears that are in the head, and we can overcome this with really good organization, approach, mindset, and tools that are more and more available these days. And again, this is really impressive, and thank you for this.
Yeah, absolutely. I fully agree that you know, so much needs to be acknowledged about the importance of change management. I can't tell you how many initiatives I've started because, like, oh, it's such a great idea and it should be so easy. But when you need to change minds and change practice, there are actual ways that you need to invest in that sort of education, training, and the infrastructure to be able to stimulate change. That has been the biggest challenge of anything. It is not technology that is the barrier; it's the people. So, and honestly, technology works better when people are willing to experience it. So, one of the things we did at Mercy Virtual was we worked directly with the software development team, and so we used software that did not work the way we wanted it. But again, we worked directly with the development team, and so we were constantly changing things, and we were accepting things as they were and being able to try it and give feedback. Because if you never get started, and if you never start with something, and if you expect a perfect solution right away, then you might never move in the right direction. And a lot of people worry that, what if I put lives at risk by implementing new technology? So, when I challenge people, when we talk about like the emergency and critical care stuff, I say, okay, there is a 0% chance that you are going to get a full-time emergency pediatric physician in every single rural community. It's just not going to happen. So then you can't compare care over video to care in person, because you're never going to have that expert care in person in all those communities. But there always needs to be a safety backup. So, if we were to implement a video consult program to rural emergency departments, that improves the access that those kids have to specialty care. But let's say the video cart breaks or won't connect, you always have the option of reverting to the current standard of care. You can always pick up the phone and just do what you would have done a year ago. And so building those kind of safety measures into any telehealth program is really important, and definitely will be needed when you're trying to kind of win over your clinicians and get them to try something new.
And I guess this is the key message, as you mentioned. Education here is the key, and education on an academic level, on a hospital level, on a management level, and I hope this is what we are trying to do here with K.I.D.S. It's to bring in innovation, not only to the hospitals and the solution itself, but to bring the innovation as well to the education and to those stakeholders that need to be addressed and need to hear this lecture and this voice. Yeah.
Well, thank you again for having me, and feel free to reach out if any of you have additional questions. I am going to have to go because I have to go upstairs and work in the emergency department, but I really appreciate this opportunity.
That was an honor. Thank you very much, Dr. Kaufman, and I think, and I'm pretty sure that we're going to reach out and we're going to have contact again. Thank you again. Take care. Bye-bye.